Hi, my name is Brian. I'm a current PGY1 pharmacy resident at Champlain Valley Physicians Hospital, part of the University of Vermont Health Network. Today we'll be taking a look at the perioperative management of patients receiving anticoagulants for the treatment of atrial fibrillation. By the end of our discussion today, we will have gone through some pertinent recommendations from the 2017 ACC Expert Consensus Decision Pathway for peri-procedural management of anticoagulation in patients with non-valvular AFib. We'll take a look at the PAUSE study, which was published in 2019, talk about the methodology results, limitations and strengths, and some of the clinical implications we can take away from this study. And then we'll look at a patient case and design an appropriate plan for the perioperative management of anticoag for a given patient with atrial fibrillation. To start off, we'll go ahead and introduce our patient case for today. We have LG. He's a 68-year-old male. He's coming in. He has a complaint of left foot wound that's probing down to the underlying bone, and there is a concern for osteomyelitis. He underwent partial transmetatarsal amputation of his left foot a few months ago, back in December, due to digital ulceration and subsequent infection. Since then, he has had subsequent further breakdown along the lateral incision, which is now probing to the underlying bone. He had a recent x-ray done that was suggestive of osteomyelitis, and the plan now is that LG is scheduled for a revision amputation as well as left foot wound and bone debridement on the 18th of February. Looking at his past medical history, he's got a history significant for end-stage renal disease. He is on hemodialysis intermittently. He has a history of atrial fibrillation, type 2 diabetes, along with diabetic neuropathy. He has coronary artery disease history with a stent placement about a year ago. He has diastolic heart failure with preserved ejection fraction, history of colon cancer, benign prostatic hyperplasia, psoriasis, as well as hypothyroidism. Moving on now, we can see LG's past surgical history, as we talked about on the last slide. We can see most recently LG had a left foot wound debridement as well as a partial transmetatarsal amputation of rays 3, 4, and 5 back in December of 2020. Looking at his social history, when questioned, LG denies any alcohol, tobacco, or illicit drug use, and he has no known drug allergies. LG's home medication list is as follows. We can see for the treatment of AFib, he is anticoagulated with apixaban 2.5 milligrams by mouth twice a day. Of note, this is the low dose. After reviewing his profile, looks like he has a history of rectal hemorrhage about 6 months prior on the 5 milligrams by mouth twice a day dose, so is subsequently reduced to the lower dose thereafter. See, he's got diclofenac gel as needed. He takes a bowel regimen consisting of Docusate as needed, as well as Miralax. He's on famotidine once a day, fluoxetine 40, gabapentin 300 BID for his peripheral neuropathy. He's insulin dependent. You can see he's on 26 units of Detamir at bedtime, along with 6 units 3 times a day for his mealtime coverage with Aspart. Takes levothyroxine 50 micrograms in the morning. He's on metoprolol tartrate, 12.5 milligrams twice a day, mitogen 5 milligrams twice a day, as well as tamsulosin at bedtime. Here we can see LG's baseline labs prior to his procedure. Looking at his general chemistry, again, he is on hemodialysis 3 times a week, so we can see that reflected in his creatinine and his BUN. He had an elevated phosphorus at 7.7. His LFTs look normal. His MAG is within normal range. Looking at his hematology, we can see that he is chronically anemic given his hemodialysis. He has a hemoglobin of 9.9. Here we have LJ's vitals. We can see his height, weight, and BMI were obtained prior to his procedure on the 18th of February. His vital signs, the first documented recordings we have, are from following the procedure about 2 hours afterwards. So before we get further into our discussion, we do have a few different self-assessment questions for you to consider. If you want to think about how you'll answer these, we will come back to these at the end of our discussion. The first question we have is, what is LG's CHA2DS2-VASc score? Our next self-assessment question is, what is LG's has bled score? Because we know LG is now going for a procedure and he is on his apixaban for atrial fibrillation, how long should LG's apixaban be held prior to his procedure? And now moving on to our last self-assessment question, number 4. How long after his procedure should LG's apixaban be reinitiated? To begin our discussion, I've included a general overview slide of what we'll be discussing on the next upcoming slides. When we think about perioperative management of anticoagulation, we'll think about it in a stepwise approach in sort of 3 distinct phases. So we'll think about anticoagulant interruption, whether or not we want to actually interrupt anticoagulant therapy, and then if we do, when to actually interrupt surrounding a procedure. The second part will be anticoagulant bridging, again, whether or not bridging is actually indicated, and if so, how we will bridge. And lastly, when and how we're going to restart anticoagulation in our patients. As you'll see, one of the most important aspects of appropriately managing anticoagulation in the perioperative setting is being able to adequately assess a patient's bleed risk. There's been several different scoring tools that have been proposed to evaluate bleed risk in patients with AFib. However, to date, the most widely accepted and widely used scoring tool we have is the HAS-BLED tool. As we can see here outlined on the left, the HAS-BLED tool consists of 9 different components. Each component earns the patient a 1 point, and there's a total score of 9 that a patient can achieve. So a score of 3 or greater is highly predictive of bleeding events using the HAS-BLED score. There's also some other specific risk factors that we can think about in the perioperative setting, in addition to the HAS-BLED score, when we look at the overall assessment of patient bleed risk. Things like prior bleed within 3 months, quantitative or qualitative platelet abnormality, INR above therapeutic range at the time of procedure, patient who has a bleed history from previous bridging attempts or a bleed history with similar procedure in the past. We will take those risk factors into consideration in addition to the HAS-BLED score to kind of get an overall general assessment of the patient's bleeding risk. In addition to assessing a patient's bleed risk, it's also important to be able to assess a patient's thrombotic risk, particularly when we think about patients who are on warfarin and we think about the need for bridging in these patients in the perioperative setting. Although it's not validated in the perioperative setting, the CHADS-VAS score can be used to assess an individual patient's overall thrombotic risk. As your CHADS-VAS score increases or as your thrombotic risk increases, as we'll see, the need for bridging becomes more apparent, typically unless there's a compelling risk of bleeding that's present in the patient as well. So as we can see here, CHADS-VAS score a total of 9 points, low risk being considered a score of 1 to 4, moderate risk being 5 to 6, and a high risk category being anything 7 or greater with the CHADS-VAS score. Another component that's important when it comes to managing perioperative anticoagulation is the assessment of procedural bleed risk. So how prevalent is bleeding with the procedure that the patient is actually undergoing. And although there are standardized definitions for bleeding that do exist, they're not typically used consistently across studies to evaluate procedural risk. More often than not, they're being used essentially to assess bleeding severity in this context. So it's kind of difficult, and the assessment of procedural bleed risk can be very subjective in some cases. Another aspect to consider is just as important as the prevalence of bleeding is its consequences. So small amounts of bleeding in certain areas of the body can be more detrimental than larger bleeding events in other locations. So this is another thing that goes into the classification of bleeding risk with a given procedure. With this 2017 ACC expert consensus, they actually compiled a list of the most commonly performed procedures, and in conjunction with multiple different professional societies, they actually classified procedures according to bleed risk, from clinically important bleed risk or low procedural bleed risk, and they also did uncertain procedural bleed risk and intermediate and high procedural bleed risk. Just a caveat though, the complexity of the specific procedures included in this list may vary. So the proceduralist opinion of the bleed risk may also vary from that proposed in the document that's linked above there. But you can, if you're interested in looking at the specific procedures, feel free to click this link. It'll bring you to a PDF with all the different charts, with all the different procedures and their accompanying classification of bleed risk. So thinking back to our stepwise approach to the perioperative management of anticoagulation, the first step is really assessing whether or not we want to actually interrupt anticoagulant therapy, and then if we are going to interrupt, when we want to interrupt. So we'll start off by talking about specifically our DOACs. The first step, we want to assess our patient bleed risk. So as we talked about a couple of slides ago, we want to look at a patient's HAS-BLOOD score, calculate a HAS-BLOOD score, look at some of those other patient-specific characteristics and factors that increase one's risk for bleeding to determine whether or not a patient is at an increased risk for bleeding. If the patient is deemed to be a high bleed risk, there's not really much data to support best practices in this scenario. Essentially, it's going to come down to clinical judgment. However, it is recommended to interrupt therapy at least as long as determined by the patient's renal function, specifically their creatinine clearance, and we'll talk about this on the next slide, or possibly longer. If a patient is not at an increased bleeding risk, then we look at the procedure itself to assess the procedural bleed risk, as we talked about on the previous slide with the different procedures and their different degrees of bleeding complications. So if the procedure is deemed to have no clinically important bleed risk, it's recommended to perform the procedure uninterrupted, and ideally in this scenario we would time the procedure at a DOAC interval trough when possible. For low bleed risk procedures as well as uncertain, intermediate, or high bleed risk procedures, we'll interrupt according to patient's renal function and their creatinine clearance, again as we'll talk about with table 4B on the next slide. So here we have two different tables that come into play when we think about withholding DOACs based on procedural bleed risk. The top table there for A gives an estimated drug half-life according to a patient's creatinine clearance, and it breaks it down based on specific agent. So whether it's your dabigatran or it's your direct-acting oral 10A inhibitor. For your table 4B on the bottom there, it has then your suggested duration for withholding a DOAC based on procedural bleed risk. So we can see there on the left-hand side, we have your low bleed risk procedures, and then you have your uncertain, intermediate, or high bleed risk procedures. And then across the top, depending on your creatinine clearance as well as the agent the patient is taking, this will determine the period for withholding the DOAC prior to procedure. The duration for withholding in this case is actually based off of an estimation of the DOAC half-life. And in this scenario, the recommendations are generally 2 to 3 half-lives for a low procedural bleed risk and 4 to 5 drug half-lives for those other procedures that are either uncertain, intermediate, or high bleed risk as far as the withholding period prior to that procedure. Here we just have a visual representation of what we discussed in the past couple of slides regarding interruption of DOAC therapy. So again, like we talked about, the first step is determining patient bleed risk, whether or not they're at an increased risk of bleed. If they are, there's not much data to support best practices, so we're essentially using clinical judgment. If not, then we look specifically at the procedural bleed risk to determine whether or not to interrupt. In the cases of no important bleed risk, we're essentially recommended to perform the procedure uninterrupted. For your low, uncertain, intermediate, or high, again, we look at that the table that we saw, table 4B on the previous slide, and a patient's creatinine clearance to determine the period for withholding a DOAC prior to a procedure. So once again, once we've determined that we are going to interrupt, then we want to consider when to interrupt therapy. And again, just reiterating, this withholding period and the recommendations for withholding DOAC therapy prior to procedure comes directly from that table 4B that we saw before. So all of this is the same, just represented in a little bit of different way. So now we'll go ahead and move on and talk about anticoagulant interruption as it relates to warfarin therapy. So again, like our DOACs, the very first step is assessing a patient bleed risk, so determining whether or not they're at an increased risk for bleeding. The next step, whether or not the patient is at an increased risk of bleeding, is going to be to assess the procedural bleed risk. So if the patient is at a heightened risk for bleeding, We look at procedural bleed risk if it is not clinically important or if it's a low procedural bleed risk. There's really not much data for best practices. Again, it's going to be a lot of clinical judgment in this case, but we will likely interrupt therapy in that case. However, if there's not a persistent concern for bleeding, we may also consider performing the procedure uninterrupted in that scenario. For those procedures that are uncertain, intermediate, or high risk, we'll talk about how we actually interrupt on the next slide. And then for patients who are not at an increased risk of bleed, again, determining procedural bleed risk. For those procedures that are not clinically important or have a low procedural bleed risk, we can perform that uninterrupted. For those that are uncertain with regard to their procedural bleed risk, similar to what we talked about before, there's really insufficient data in this case. You are likely to interrupt in this scenario. However, if there's no persistent concern for bleeding, you can also consider performing the procedure uninterrupted. And then again, for your intermediate or high bleed risk procedures, we'll talk about on the next slide how we actually manage that. So once we've determined whether to interrupt therapy with warfarin, then we determine when to interrupt therapy. So ideally, we get an INR measurement 5 to 7 days prior to the procedure, and then that INR is going to guide our decision on when to withhold warfarin therapy. So for a INR that comes back super therapeutic or greater than 3, it's recommended to discontinue at least 5 days prior to the procedure. If you're within goal, you want to discontinue at 5 days prior to the procedure, whereas if you're subtherapeutic or less than 2, you can discontinue roughly 3 to 4 days before the procedure. In all these cases, we want to recheck INR about 24 hours prior to the procedure just to assess where we're at before we actually undergo the procedure. Once again, here we just have a visual representation of what we discussed on the past couple slides. Similar to our DOACs, we saw that the first step is assessing a patient's bleed risk, determining whether or not they're at an increased risk for bleeding, and then we move down into assessing the specific procedural bleed risk to determine whether or not to actually interrupt warfarin therapy. For those patients in whom interruption of warfarin therapy is indicated, we look at an INR measured at least 5 to 7 days prior to the procedure to guide us on how to withhold warfarin prior to that given procedure. So if the INR is super therapeutic, we want to discontinue warfarin at least 5 days prior to the procedure. For your patients who come back with a therapeutic INR, discontinue 5 days prior. And then those who are subtherapeutic, we want to discontinue 3 to 4 days before the procedure. And then for all these instances, we want to recheck INR 24 hours before the procedure to get an idea of where the INR is. The next component of our stepwise approach to the management of perioperative anticoagulation is determination of whether or not to bridge, as well as how to bridge with parenteral therapy. Starting off with our DOACs, it's easy enough. For our DOACs, we do not bridge, so the use of parenteral agents for bridging is not indicated in patients who are on DOACs. There are really only a couple of instances where bridging with a parenteral anticoagulant is indicated, and this is going to be in our patients who are on warfarin. So when it comes to working up our patients taking warfarin to determine whether or not to bridge, we first want to assess patient bleed risk like we have been doing previously as far as interrupting our DOACs or our warfarin. With this, we then want to look at our patient thromboembolic risk, and we're going to, again, like we talked about earlier in the discussion, we'll take a look at a patient's CHADS-VAS score. We'll also look at a patient's history of thromboembolism, as well as the timing of thromboembolism if they do have a history. That will play a part in kind of stratifying these patients according to their thrombotic risk. So for those who are deemed to have a low thrombotic risk, recommendation is not to bridge with parenteral anticoagulation. For those at a moderate risk, however, we then look at a patient's bleed risk. If they're at an increased risk of bleed, the recommendation is to not bridge. If they are not at an increased risk of bleed, however, then it comes down to clinical judgment in this case. But one thing we can look at is whether or not the patient has had a prior history of stroke or TIA. If they have, they're considered to be, at a potentially increased risk of thromboembolism in this specific subset of patients. So in that case, you might be more inclined to bridge in that scenario. Whereas if they had not had a prior stroke or TIA, the decision is likely not to bridge. However, again, both of these scenarios will be up to clinical judgment. For patients at high thrombotic risk, specifically those with a recent thromboembolism, the recommendation is to bridge, and if we can, we want to consider delaying the procedure in these patients. Then we want to assess the patient's bleed risk. Again, so if a patient is not at an increased risk of bleed, but has a high thrombotic risk, then the recommendation is to bridge. However, if the patient is at an increased risk of bleed, as well as a high thrombotic risk, then this is a more gray area, and this is going to, again, come down to more clinical judgment in that case. For those in whom bridging with parenteral anticoagulants is indicated, specifically in our patients who fall in that subset of high stroke risk with a high thrombotic risk, as well as that increased bleed risk, there's really not any good recommendation to guide bridging in this scenario, but they do recommend using an individualized strategy. You might consider a prophylactic dosing or a low-dose parenteral anticoagulant, or maybe considering only doing a post-operative bridging in these patients. For patients who are not at a high stroke risk and they are at an increased bleeding risk, then we want to consider whether or not the patient has a heparin allergy or recent HIT. Then we'll follow our local protocol and management for HIT and heparin allergy in these patients. The next component is looking at a patient's renal function, whether or not their creatinine clearance is adequate enough to be on low molecular weight heparin. If not, we'll start unfractionated heparin when the INR is less than 2, and it's recommended to discontinue at least 4 hours prior to the procedure. If a patient is decided to be bridged with low molecular weight heparin, then the recommendation, again, still want to start low molecular weight heparin when INR is less than 2. However, the discontinuation period is going to be 12 to 24 hours prior to the procedure, and this is going to be based on renal function and whether the dose is being administered once daily or every 12 hours. So here we have the visual algorithm for the assessment of bridging, particularly in our patients on warfarin. We can see those on DOACs. Bridging is not indicated. In our patients on warfarin, the assessment starts with looking at patient bleed risk as well as thrombotic risk, and then having that drive essentially whether or not we're going to bridge. The most compelling indication for bridging is in our patients who have a high thrombotic risk and have had a recent thromboembolism, being in the last 3 months, or those with a high thrombotic risk without a recent thromboembolism in the past 3 months. However, they're not at an increased risk of bleed. So these patients really have the most compelling indication for undergoing bridging with an parenteral anticoagulant agent in the perioperative setting. As I mentioned, with our patients who are at high stroke risk and also an increased bleed risk, there's not really any solid recommendations for guiding how to bridge in these patients. However, we'll consider a more individualized strategy, such as the prophylactic or low-dosing parenteral anticoagulants in that setting. If not, then we look at the patient whether or not they have a heparin allergy or recent HIT. If so, then we'll treat accordingly. If not, however, then we'll look at renal function to determine whether or not we're going to use a low molecular weight heparin or unfractionated heparin. And then the recommendations for starting our parenteral anticoagulant, in that case when INR is less than 2, and then discontinuation of unfractionated heparin at least 4 hours prior to the procedure, and then our low molecular weight heparin is going to be 12 to 24 hours prior to the procedure. The third and final component of our stepwise approach to management of anticoagulants in the perioperative setting is determining whether and when to restart anticoagulants. We'll start by looking at our DOACs. As you'll see with both our DOACs and our warfarin, the first step is determining whether or not complete hemostasis has been achieved and there's no bleeding complications, no high bleed risk features of the patient, and there's an absence of potentially catastrophic bleed locations such as intracranial or intraspinal bleeds. If any of these are present, then it really comes down to clinical judgment in determining when to restart anticoagulants. However, assuming all of these are achieved, Then we look at whether or not a patient is able to tolerate oral medications, and then we look specifically at the patient's post-procedural bleed risk, whether or not it's low or high will determine the duration of withholding an anticoagulant following a procedure before reinitiation. So in our patients who are able to tolerate oral medications and have a low post-procedural bleed risk, we'll initiate a DOAC within 24 hours. If they are at a high post-procedural bleed risk, the recommendation is to delay that out to 48 to 72 hours after the procedure. In our patients who can't tolerate oral medications with a low post-procedural bleed risk, the recommendation is consider starting a parenteral anticoagulant. In the meantime, you can initiate it within 24 hours of the procedure. And for those with a high post-procedural bleed risk, again, we want to consider starting a parenteral anticoagulant. However, we'll consider delaying this out to 48 to 72 hours in this case until a patient is able to tolerate PO medications. Moving on to our patients on warfarin, again, we'll take a look at the same components to see whether or not they apply as far as achievement of complete hemostasis following a procedure. Then the decision on when to restart warfarin therapy actually comes down to whether or not there's a plan or indication to administer parenteral agent after the procedure, so whether or not there's an indication for bridging, essentially, with a parenteral anticoagulant. If there is, then we look at the post-procedural bleed risk. For those with a low procedural bleed risk, we'll start warfarin within 24 hours of the procedure, and similarly, we'll restart parenteral agent within 24 hours of the procedure, and DC the parenteral agent when the INR reaches 2. For those with a high post-procedural bleed risk, again, we'll still start the warfarin within 24 hours. However, the recommendation is to delay restarting the parenteral agent out to 48 to 72 hours after the procedure, and again, DCing the parenteral agent when the INR again reaches 2. If there's no plan or indication for parenteral bridging to warfarin, we'll just go ahead and reinitiate warfarin within 24 hours following the procedure. For those that would prefer a visual representation of what we discussed, I have also included the algorithm for how to restart anticoagulation, so feel free to go through that as you would wish. For the remainder of our discussion today, we're going to shift gears a little bit and talk about an interesting study that was published back in the end of 2019, the PAUSE trial, or the Perioperative Management of Patients with Atrial Fibrillation receiving a direct oral anticoagulant, and we'll talk about some of its clinical implications in practice moving forward. The PAUSE trial was a cohort study, and it set out to assess the safety of implementation of a standardized perioperative management strategy for a DOAC regimen. It looked at patients who were 18 years and older that had atrial fibrillation and were long-term users of either apixaban, dabigatran, or rivaroxaban for the treatment of their atrial fibrillation. Patients were also included. They had to have scheduled an elective surgery that required interruption of their anticoagulant regimen, and they had to have been able to adhere to DOAC therapy interruption protocol at the time of their enrollment. Some key exclusion criteria for this study included those with a creatinine clearance less than 25 for apixaban users, or creatinine clearance less than 30 for those on dabigatran or rivaroxaban. Any patients who had cognitive impairment or psychiatric illness were excluded from the trial. Those who did not consent or were previous study participants, and those with more than one procedure planned within 30 days were all excluded from participation in the PAUSE trial. The intervention in this trial was the implementation of a standardized management protocol for the perioperative management of DOACs. For their primary outcome, they looked at major bleeding, and they also looked at arterial thromboembolism, which encompassed ischemic stroke, TIA, as well as systemic embolism. They looked at a number of different secondary outcomes, including clinically relevant non-major bleeding, minor bleeding, death, MI, DVT, PE, as well as catheter-associated venous or arterial thrombosis. So as I mentioned on the previous slide, the intervention in this study was actually pretty interesting. They implemented a standardized protocol for the perioperative management of DOACs in these patients with atrial fibrillation. Because it was a cohort study, they actually didn't have a comparator arm, So they just looked at these patients who were managed using this standardized protocol. The goals of this strategy was to have the shortest duration of DOAC therapy interruption both before and after the procedure in order to sort of minimize the risk associated with both bleeding as well as thromboembolism. And they also wanted to have a simple interruption and resumption protocol for each DOAC that was going to be easily implemented by clinicians and easily understood by patients. The DOAC management strategy that they came up with was based on DOAC pharmacokinetic properties. It was also based on procedure-associated bleeding risk as well as patient renal function, specifically their creatinine clearance level. Here we have the standardized protocol that was implemented both for DOAC interruption as well as DOAC resumption following the procedure. We can see on the left-hand side we have all our DOACs listed out there that were included. Apixaban, dabigatran, we have two different subsets of patients which we'll talk about, as well as rivaroxaban. And then next to that we have the accompanying surgical procedure associated bleeding risk, which was used to determine the period for withholding the DOAC prior to the procedure. In the standard protocol that was implemented, the duration of withholding the DOAC prior to the procedure was based solely on the procedural bleed risk. So those procedures that were associated with a high bleed risk, the DOAC was held 2 days prior to the procedure. If the DOAC or if the surgical procedure was a low bleed risk procedure, the DOAC was held 1 day prior. The only exception to this was the subset of patients that were on dabigatran that had a creatinine clearance of less than 50. This was actually extended from the standard protocol out to 4 days prior to for the high bleed risk procedures and 2 days prior to procedure for the low bleed risk procedures. For your low bleed risk procedures, following procedures, DOACs were resumed about 1 day following the procedure. There was some leeway in that, but the average was 24 hours. And then the high bleed risk procedures, DOACs were resumed 2 to 3 days, or an interval of anywhere from 48 to 72 hours following the procedure. Here we can see the baseline characteristics across our 3 different DOAC cohorts. We can see the mean age for our patients included in the trial was 72.5 years old. 66% of patients were male. As far as baseline thrombotic risk, the mean CHA2DS2-VASc score at baseline was 3.4 across the cohorts. Looking at baseline bleed risk, the mean modified Hasbled score was a 1.9 at baseline. As far as renal function, the mean creatinine clearance was 82 mils per minute. And then for procedural bleed risk, it was split. About a third of patients were undergoing high bleed risk procedures, and about 2/3 of patients were undergoing procedures that were deemed to be of low bleed risk. When looking at adherence to the standardized protocol, we can see that of the 3,007 patients that were included, only about 5.3% deviated from the DOAC interruption protocol, whereas 6.7% deviated from the DOAC resumption protocol. We only had 22 patients out of the total, so about less than 1% were actually lost to follow-up. So overall, there was a total of 2,624 patients, or 87.3% of the patients that actually adhered per protocol and were eventually included in the per protocol analysis cohort. Moving on to the primary outcomes of the study, which again were assessed at 30 days post-op. So for the primary outcome of major bleeding, we can see across the 3 cohorts, the rate of major bleeding was actually pretty low, falling in less than 2% in all of the 3 cohorts. We can see 1.35% for the apixaban cohort, 0.9% for the dabigatran group, and then 1.85% in the rivaroxaban cohort. Similarly, the rate of arterial thromboembolism was also very low among the 3 cohorts, with a rate of 0.16% in the apixaban group, 0.60 in the dabigatran group, and 0.37 in the rivaroxaban cohort. Moving on, now we can see some of the rates of the secondary outcomes that were assessed in the trial, which again were looked at 30 days post-op. So the rate of death was very low in all 3 cohorts, less than 0.5% for all groups. MI only occurred in 1 patient in the apixaban group. DVT only occurred in 3 total patients, 2 in the apixaban group, 1 in dabigatran group. Similarly, PE was also another low rate occurrence with 4 patients in the apixaban group, 1 in dabigatran and 1 in the rivaroxaban group. Arterial catheter thrombosis occurred only in 2 patients, 1 in apixaban, 1 in dabigatran cohorts. Clinically relevant non-major bleeding occurred in less than 2% in the apixaban and dabigatran groups, but occurred in 2.4% of the rivaroxaban treated patients. And as far as minor bleeding goes, there was a little bit more increased incidence of minor bleeding across the 3 cohorts. We can see right around 5% for most, 4.3% in the apixaban group, 5.69% in the dabigatran group, and 5.73% in the rivaroxaban group. The PAUSE trial had a number of strengths with it, one being the baseline thromboembolic risk that was according to the CHAS-VAS score at baseline was deemed to be similar to that of patients with atrial fibrillation from other population-based studies. So we know that this cohort of patients that was included in this trial and managed using this simplified management protocol was actually fairly representative of the general thromboembolic risk of the general atrial fibrillation population. And with that, there was also some pretty strong external validity with the study. It was multi-center, it was international, it occurred across multiple different clinical sites. As far as screening and enrollment, 83% of patients that were actually screened were enrolled, which shows that a lot of patients were able to meet the inclusion criteria. So the inclusion criteria captured the wide majority of patients that were eligible. There was also pretty impressive follow-up, with only less than 1% of patients being lost to follow-up. Because of the simplicity of the standardized DOAC management protocol, there was also very high rates of adherence, with 95% adherence to DOAC interruption and 93% for DOAC resumption. Thinking about their outcome measures that they utilized, they extended their outcomes to 30 days, which is likely an adequate period to detect any postoperative complications that they might expect. So this was a benefit in that regard, in that the outcomes at 30 days are likely to encompass any of these post-op complications that may have occurred. Also, the assessors of outcomes were actually blinded to both DOAC therapy. They were also blinded to procedural bleeding risk and the preoperative residual DOAC levels that were measured. When assessing outcomes, they had no knowledge of this prior to. The PAUSE trial did have several key limitations with it, one being the cohort study design, which may introduce a degree of selection bias in choosing the patients that were enrolled in the study. Also, when we looked at the dabigatran cohort, they actually did not reach their expected sample size based on their sample size calculations that were pre-specified. There's also some limitations to the external validity, although in general they did have a pretty strong external validity. They didn't include any patients who were using edoxaban, so we don't know how these results apply to these patients. Most patients were also white males, so there's really not much data extending beyond that population. And then we also did not include patients who were receiving DOACs for VTE treatment. These patients were not excluded, so we don't know how these patients can be managed as far as in the perioperative setting. There was also no information provided regarding baseline bleed risk. Essentially, we didn't know what the rate of major bleeding from these procedures was in general in patients who were not on DOACs. So it's hard to kind of gauge a sort of safety in that regard, where we didn't have a baseline comparator to kind of use head-to-head to compare the data points to. The bottom line of the study was that in a cohort of patients who had atrial fibrillation with a DOAC therapy interruption for elective surgery or a procedure, and were managed using a simple standardized perioperative management strategy that did not include heparin bridging, it was associated with low rates of major bleeding and arterial thromboembolism, and essentially overall was deemed to be safe in these patients. So now on the last few slides, we'll tie back into our patient case, LG. So we have his OR report from the 18th. So as far as procedures, he underwent a left foot revision, partial transmetatarsal amputation with adjacent tissue flap closure, wounded bone debridement with bone biopsy, as well as left foot sonogram. His wound classification was clean contaminated. He underwent monitored anesthesia care with local anesthesia as well. As far as blood loss, there was an estimated blood loss of less than 20 mils. And then for findings, we see the plantar foot ulceration was probing to underlying bone. There was no evidence of frank pus. Some evidence of necrotic tissue, which was debrided to healthy appearing tissue. And then the distal ulceration was probed to a plantar sub-fifth metatarsal ulcer. So looking back at our first self-assessment question, which was, what is LG's CHADS-VASc score? We can see that the correct answer here would be C, 3. If we look at the CHADS-VASc criteria, we can see that LG, looking back at his history, has a history of heart failure. He does not have a hypertension history. He is not older than 75 years old. He does have diabetes, does not have a past history of stroke, TIA, or thromboembolism. He has no vascular disease history. He does fall between the ages of 65 and 74, and he is not female. So his CHADS-VASc score would be 3, which puts him at a low risk with an annualized estimated stroke risk of less than 5%. Moving on to our self-assessment question number 2, which was, what is LG's HAS-BLED score? So the correct answer here is going to be C, 4. If we look at the HAS-BLED criteria on the right, again, LG does not have hypertension. He does have abnormal renal function, being on chronic dialysis. He has no abnormalities in liver function. He does not have a history of prior stroke. He does, however, have a history of major bleeding. As you saw 6 months prior, his apixaban dose was reduced to 2.5 BID due to rectal hemorrhage. He does not have label INR. He is greater than 65 years old, so he does classify as elderly. And he is on concomitant NSAID therapy, even though he's on the diclofenac gel. And the topical formulation doesn't have very much absorption systemically. It's still up to 10% of it can be absorbed systemically, and there still is the increased risk of bleeding. I did go ahead and include that in his calculation. And then he denied any alcohol or drug use, so he does not qualify for bullet point number 9 there. So again, his total score is going to be 4 on the HAS-BLED score. In one validation study, a score of 4 was associated with an 8.9% risk of bleeding and an 8.7 bleeds per 100 patient years. So again, looking at a score greater than 3 being highly predictive of bleeding events, he would qualify as having a high bleed risk according to his HAS-BLED score. Looking back at our self-assessment question number 3, how long should LG's apixaban be held prior to his procedure? Going back to the 2017 ACC Expert Consensus Panel, when we talked about interruption of DOAC therapy, the first step is determining procedural bleed risk to help us determine the duration for withholding apixaban or your other DOACs prior to a procedure. In this particular case, I wasn't able to find what the actual classification was for the specific procedures that LG underwent in his procedure. So I was unsure of what the actual procedural bleed risk would be, whether it would be low or whether it would be more appropriate to classify it as being uncertain, intermediate, or high based on the procedures that he underwent. I believe that it's probably more up to the discretion of the proceduralist to determine that and use their clinical judgment in determining that procedural bleed risk. However, if the procedure was deemed a low bleed risk procedure, we look at the patient's creatinine clearance, and again, it's difficult because the patient is a chronic dialysis patient, so there's not much data for that, and there's not many specific recommendations for dialysis patients in the ACC consensus guidelines. But for patients with the lower range of creatinine clearance, we see that for low-risk bleed risk procedures, the recommendation is to withhold a DOAC for at least 48 hours, and you may consider getting a anti-10A level prior to the procedure. For those procedures that are of high bleed risk or intermediate bleed risk, or the bleed risk is uncertain, then you want to be more conservative for those patients, particularly with those patients with poor renal function, specifically or creatinine clearance less than 30, and you want to withhold at least 72 hours in that case, and again, consider getting an anti-10A level prior to procedure. Moving on to our last self-assessment questions, question number 4. We have, how long after the procedure should LG's apixaban be reinitiated? When considering reinitiation of anticoagulants following a procedure, again, we want to look at a patient's post-procedural bleed risk, and this is going to be based on some of those patient-specific factors and risk factors that we talked about, along with consideration of patient's HAS-BLED score. So if we look at some of the specific patient factors that they consider increasing a patient's bleed risk, so if you have a major bleed or intracranial hemorrhage less than 3 months, any quantitative or qualitative platelet abnormalities, including aspirin use or prior bleed during previous bridging, any of these would deem a patient at a high bleed risk. So again, our patient LG does not meet any of these criteria, so we would consider him a low post-procedural bleed risk. And following the algorithm, in that case, it's reasonable to reinitiate a DOAC within 24 hours of the procedure. There is also that caveat that you may consider reducing the dose of the evening dose on the day of the procedure. So that's also an option in that situation. So here now we can see how our patient LG was actually managed in the perioperative setting. We see his apixaban was held beginning the 16th, which was 2 days prior to his procedure on the 18th. It was reinitiated at 2100 on the day of his procedure. So that means his total anticoagulant-free interval was about 72 hours on the dot, which encompassed about 60 hours before his procedure, give or take 1 hour during his procedure, and then 12 hours following the end of his procedure. Looking back at the 2017 ACC Expert Consensus Panel, we can see that as far as DOAC interruption prior to the procedure, how he was managed actually aligns pretty closely with their recommendations, with the DOAC interval being at least 48 hours prior to the procedure. We can see even with reinitiation, the recommendation for him, he would have fallen into the reinitiate the DOAC within 24 hours, which did happen in this particular case. However, we could see that his PM dose was given the full dose. We may have considered either skipping this dose for him or potentially reducing the dose of his evening dose had he been on the full 5 milligrams twice a day. However, since it was already reduced, I think it was completely appropriate to go ahead and reinitiate at the normal home dose about 12 hours following his procedure on the 18th there. So just to summarize some of the key aspects we went over today in our discussion, so when we think about the decision to interrupt anticoagulation, essentially we're looking at the type of anticoagulant the patient is on. We're looking at an assessment of the patient bleed risk, as well as an assessment of the procedural bleed risk to guide our decision whether or not to interrupt anticoagulation. The next step in our stepwise approach, we looked at bridging with parenteral agents. In general, really should only be considered for warfarin-treated patients who are at a high thrombotic risk but are not at an increased risk for bleeding. These patients have the most compelling indication for bridging with a parenteral agent in the perioperative setting. The last step to consider in the perioperative management of anticoagulation is reinitiation of the anticoagulant after a procedure. And as we discussed earlier, this really depends primarily on the post-procedure bleed risk. In general, though, our warfarin can be reinitiated within 24 hours of procedures, and then parenteral bridging, if indicated, will reinitiate within 24 to 72 hours, depending, once again, on that post-procedural bleed risk. For our DOACs, again, we want to look at that bleed risk to consider when we'll initiate. However, the recommendation is generally from 24 to 72 hours after the procedure is recommended. We looked at the PAUSE trial, which showed that in general, for most of our patients with atrial fibrillation that are undergoing a low bleed risk procedure, we saw that it was essentially safe to stop our DOACs a day prior to the procedure and then resuming them 1 to 3 days after surgery. So this method appeared safe, and it may be an indication that we can implement some of these simplified strategies, such as the one seen in the pause trial, in our general patient population when we think about managing their perioperative anticoagulation in the future. With that, we'll go ahead and conclude our discussion today on the perioperative management of anticoagulation for patients with atrial fibrillation. Thank you guys for joining me and listening. If you have any questions or comments or concerns, feel free to reach out to me. My email is on the first slide of the slideshow if needed. Or if you would like, feel free to leave a comment down below and I'll get back to you guys as soon as I can. Thanks again.